Next speaker is Professor Annalise Zemlin, is Head Division of Clinical Chemical Pathology, National Health Laboratory Services, and University of Stelbach at Hyderabad Hospital is the tertiary care hospital associated with the University of Stelbach. She is chair of the IFCC Committee on Evidence-Based Laboratory Medicine, and previously she was IFCC Public Relations. She is also founder member of the College of East, Central, and Southern Africa, which was founded at Kampala in 2010. And now, Professor Annalise Zemlin, Inter Virtual Platform is yours. Please welcome.
Thank you. Thank you very much for that introduction and for the organizers for this invitation. And yeah, especially to Dr. Seema, who is an active member of the IFCC EBLM committee. So I'm honored to be part of this. Okay, let's go. All right, so the talk will be divided into two. So I'm basically first going to talk about EBLM, or evidence-based laboratory medicine, a bit of definition and history, the steps involved in appraising the evidence, and some of the challenges. And then the second half of my talk will be about audits, step-to-step approach to conducting an audit or clinical audit, and some of the experience that we have in our division. So I always like putting this slide in when I give a talk to laboratory personnel, because I think we need to encourage ourselves, and often clinicians think that we sit in the laboratory and don't really do much except spit out results. But I like this statement from this article by Forsman in ClinChem in 1996, which says that although the laboratory represents a small percentage of medical center costs, it leverages 60 to 70% of all critical decisions, such as admission, discharge, and drug therapy. So like that little cartoon at the bottom says, without the lab, we're only guessing. So the evidence of the definition of evidence-based medicine. So evidence-based medicine, there was a lot of literature about it in the early mid-90s. And Sackett is the so-called father of evidence-based medicine from McMaster University in Canada. So the definition of evidence-based medicine is conscientious, explicit, and judicious use of current best evidence in making decisions about the care of the individual patient. So it's the integration of best research evidence with clinical expertise and patient values. So as I said, evidence-based medicine is using the best evidence to guide clinical decision-making in the care of patients. And laboratory medicine specializes in the performance, reporting, and interpretation of laboratory tests. And these results are used to screen, diagnose, monitor, determine prognosis of the patient's health and disease. So therefore, evidence-based laboratory medicine is using the best evidence in the utilization of laboratory tests to assist clinical decision-making in order to improve care and outcomes of individual patients, and importantly, to promote effective use of healthcare resources. So the overall aim is to improve patient outcomes. So this is just a graph showing the interest of evidence-based medicine. So it's PubMed searches for the term evidence-based medicine and PubMed searches for the term guidelines. And we can see that there's a definite increase from the 1990s. So what are the challenges with finding this evidence? Obviously, we have this absolute information overload. We know that there are numerous biomedical journals and more popping up regularly. More than 17,000 new medical books are published annually. And by the time we read a book that's not an online book, it's most probably already outdated. Just looking at internal medicine, there's more than 6,000 articles per day. So obviously to get this evidence, to appraise this evidence is a tremendous task. And then we use tools such as systematic reviews and meta-analyses, where many studies are combined to look at evidence. The problem with systematic reviews is that it may include studies that are inadequate or misleading. So to evaluate evidence, we need minimal standards. We need this critical appraisal. And another challenge is that there's increasing healthcare costs. So payers want evidence that what they are paying for is worth it. And we also have the general public becoming more educated and actually coming in and wanting tests. So they're consulting Dr. Google before they actually consult their own doctor. So therefore, there is this balance between maintaining quality healthcare and clinical and economic efficacy. So why do we need EBLM? In the lab, we're under pressure to do more. We have increasing populations. We have increasing aging populations with associated comorbidities. There's chronic diseases, lifestyle diseases of lifestyle, new tests, new technologies being developed. Due to budget constraints, we need to use our resources well. There's rationalization of the laboratory, point of care, and then we have public expectations and the threat of public providers. We're also under pressure to do less. We're having our budgets cut in most laboratories. There's public sector constraints, and as I mentioned, the rationalization. So what are the steps in the EBLM process? So we need to first formulate an answerable question. Then we need to track down the best evidence. We then need to critically appraise this evidence to ensure that this evidence is indeed the best evidence. And then using this evidence, we can implement a policy. So it's a circle, it's a cycle. So we ask the question, acquire the evidence, appraise the evidence, apply the evidence, and then we need to assess that this evidence is indeed being used correctly. So the steps in evidence-based medicine research, the results are made available, and that becomes evidence, which is then acquired. The evidence is evaluated, and it's used to make evidence-based protocol and implement clinical policies, which then lead to good clinical practice. So if we look at where do we obtain this evidence, the evidence is mostly obtained from the literature, and this is our traditional evidence pyramid, where we have systematic reviews at the top as the ideal evidence, followed by critically appraised topics, critically appraised individual articles, and at the bottom we have our cohort and case control studies and expert opinions. And as we go to the top of the triangle, validity increases and the risk of bias decreases. There's been publications querying this traditional evidence triangle and saying that the lines between should not be straight because some randomized control trials may actually have better evidence. So instead of having a straight line, to replace it with curvy or wavy lines, and using the systematic reviews and the meta-analyses, which is the tip of your pyramid, as a tool through which to actually examine the so-called lower evidence. So what do we need to look for when we appraise? One of the big things we need to look for is bias. So there's various types of bias. There can be population bias. So how was the population selected that the study was done on? There can be verification bias. Was there a gold standard that the test was compared to? Review bias. If the reviewer isn't blinded to the results, this could underestimate the test accuracy. Publication bias. We all know in research, if you get positive results, more likely to get your publication accepted. Negative results often get rejected, or people feel that they don't want to publish negative results. So we have this publication bias of positive results being published. And then obviously language bias. If you are evaluating the literature, you're more likely to, or you're going to evaluate evidence in a language you understand. So an outline of the evidence-based laboratory medicine process is to ask. So we need to convert information needs into answerable, clinically relevant questions. We need to find, so we need to track down the best evidence for these answers. We need to appraise, so we need to critically appraise the evidence for validity and usefulness. And there's various tools and checklists that are available for this appraisal process. we need to act, so we need to apply the results of this appraisal into our laboratory practice or into guidelines or into care maps. And then important where audit comes in is we need to evaluate the performance of this evidence, and that is then the audit. So tools for continuous quality improvement, we have clinical guidelines, and the definition of clinical guidelines are systematically developed statements to assist the clinician and patient decisions for a specific clinical circumstance. And they're decided by experts, and it's based on the translation of research. So a lot of time and effort goes into developing these clinical guidelines. And the problem with clinical guidelines is that often by the time the guidelines are implemented, the evidence may already start to be getting outdated. And it's important that the evidence is the best evidence, because poor evidence will lead to a poor quality guideline. Then we have care maps. Care maps are optimum steps involved in the process of care, where there's standards at each step to allow for the comparison of best practice. And this is a grid with readily obtainable outcome measures, again relies on good quality evidence, and we need to ask ourselves the question, do they optimize and improve care? So it's a form of benchmarking. And then we need to, as I said, assess the outcome. So we need to assess the effectiveness of this care by reviewing and possibly updating guidelines. And this is where our clinical audits are important. So recently there's been quite a bit of criticism of evidence-based medicine and evidence-based laboratory medicine. So some critics have called it outrageously exclusionary because it does sift knowledge and exclude a lot of knowledge that is out there. And they say, or quote, that by anointing only a small sliver of research as best evidence and discarding physician judgment and more than 90% of other literature, are we maybe forcing our patients into a one-size-fits-all straitjacket? And this is where personalized medicine is starting to come in. So we need to also consider that in the future. But the best evidence-based medicine should be integrated and not at odds with medicine. So it's just a cartoon before I go over to my next part of the talk, which is on laboratory audits. So audit is a quality improvement process, and all audits share certain components. So audits examine, evaluate, and report on findings. They're concerned with ensuring that the best possible performance is being adhered to. They examine the use of resources, and they involve a lot of time, effort, and careful planning. And the baseline of an audit is it compares practice with standards or evidence. So the place of laboratory-based audits in clinical practice in the United Kingdom in 1997, clinical audit was incorporated into clinical governance as part of quality management and accreditation. And clinical governance is the system by which our laboratories are accountable for improving the quality of service. And the umbrella of clinical governance includes clinical effectiveness, research and development, risk management, education, training, and audit. So if we look at this circle, so we can see the outer cycle here is the evidence-based medicine cycle. So identifying the question, searching for the evidence, critically appraising the evidence, and applying this evidence to practice. So developing this evidence into a standard. And the inner cycle is the audit cycle. So once we have applied this to practice, we audit this practice. If there's any change needed, we modify it and we apply it back into practice. So we can see how evidence-based laboratory medicine and audit are closely linked. So what are lab audits used for? They provide evidence on the quality of care and service that the laboratory is providing, and they enable the laboratory to use processes to gather evidence that quality requirements are indeed being met by the laboratory. So the definition of laboratory-based clinical audit is a quality improvement process that seeks to improve patient care and outcomes through systematic review of pathology services that impact on patient care against explicit criteria, and importantly, the implementation of change. So if these criteria are not being met, change must be implemented to ensure that we are performing according to criteria. All right, so yes, we indicated the change is implemented, and it's important that everyone is involved in this change. So this is the cycle of audit. So it's to identify the standards, and these standards should be based on the best evidence, to collect data on your current practice or what is happening in the laboratory, and comparing what is happening in your laboratory to the standards. So what should be happening, and then planning necessary change and implementing this change, and very importantly, to then go back and re-audit to see the effect that the change has had on your laboratory. So the first step in the clinical audit is to identify what are you going to audit. So what is the problem or the issue that will be examined? And also to ensure that the design is appropriate to the topic and applicable. So sometimes it's important to consult the literature. Often if you read the literature, you can see what other laboratories are doing and maybe look at that in your laboratory. And audits can look at structure, so they can look at resources important for the delivery of laboratory tests, which can have an impact on patient care. They can look at process, so they can look at what is happening in the laboratory itself, and they can look at outcomes. So what happens to the patient? So the impact of this result on a patient, such as mortality, mobility, quality of life, etc. So how do we choose audit topics? So when we deciding what we're going to audit, we look at areas possibly where problems have been identified, and then use that as an area to audit. We look at what our customers think. So if we're getting a lot of complaints in a certain area in the laboratory, that could be an area of audit. We must consider, is there potential for improving service delivery using the results of our audit? And then important, do standards or guidelines exist? Is there something that we can compare our service against? We can look at, for example, high cost areas where we may identify ways to save money. And we can look at high risk activities where an audit might show problems or potential for improvement. So those are just some of the topics to consider. So once we've decided what we're going to audit, we need to define our criteria and standards, because the overall purpose of the audit must be written out. So when we perform audits, we actually write out a full protocol, like a research protocol, send it to ethics and get ethics approval. And we need to know what will the audit focus on. So there must be explicit statements that will define what is being measured, and there must be standards that will define the degree to which the laboratory testing should achieve. So this is what we would want to have. And these standards must be based on the best available evidence. So stage 3 is we collect our data. We must make sure that it's precise. It's quantitative data that's collected. It's about how many, how often, to what end, and these are linked, as I said, to our standards. We decide before the time a precise time period, and data or audits can be performed either retrospectively, where we go back and look at our laboratory information system, or we can decide to do a prospective audit. So once we've got all that, we compare our performance with our criteria and standards. So we look at how well are the standards being met. And theoretically, if they aren't being met by 100%, there is a potential for change. So we look at how we're performing. And once we've discussed our results, we must decide how are we going to go about with this change? What are we going to do to make sure that we adhere to these standards? So we develop action plans, and sometimes this may involve other departments in the laboratory. And the action plan may involve refinement of the audit tool if the initial measures were incorrectly assessed. So stage 6, once we've implemented our change, and this is a very important stage that's often forgotten, is we need to re-audit to make sure that we are sustaining our improvements. So just a slide or two before I finish on our experience. So this picture that I've put here, this is where I work. So this is this building in the front is the Faculty of Medicine and Health Sciences, and that's associated or affiliated with Stellenbosch University, but we're not in Stellenbosch. We're actually 25 kilometers outside Stellenbosch in a suburb called Parow. So that's our medical faculty, and the brick building behind is Tygerberg Hospital, and here on the 9th floor is where our laboratory is. So in 2007, we established an audit committee, which was the first audit committee in Africa, and we have quarterly meetings. In the beginning, it involved all divisions of all pathology divisions of Tygerberg Hospital, and it's now national, and also we have had collaboration with other countries in Africa. And all our registrars who are training to become chemical pathologists have to perform an audit as part of their training, and it needs to be written up. So these are just some of the examples of audits that we have performed. So we look at all parts of the total testing phase, and we even, the first talk in this session was on the CPC, and one of our audits here, which is an example of lack of CPC, was looking at incorrectly filled in forms for thyroid functions. We write interpretive comments for all our clinic thyroid function tests, and we went and looked at the forms and our interpretive comments, and we realized that because the forms were incorrectly filled in, some of our comments were incorrect. And some of our audits, such as the critical results audits and the hyperphosphatemia, have been used to change policy in our laboratory as well. Okay, so in conclusion, audits are essential and mandatory in pathology to evaluate that the service we provide is beneficial for patient care. Audits can establish whether we are adhering to standards which have been determined by evidence-based medicine. Audits can form part of a research project in which current practice is identified. And for an audit to be complete, these deficiencies need to be rectified and the whole process re-audited to make sure that it's being sustained. So thank you very much for the opportunity to talk, and that's just a picture of Cape Town, and hopefully one day when travel restrictions are up, I can welcome some of you to our lab in Cape Town. Thank you.
It's a really excellent talk, Madam. It's a nice presentation also, and hope we will be in your place in after COVID scenario. Thanks for invitation in your country also.
Thanks, excellent talk, Dr. Annalise. My question is regarding the quality tools and audit of POCT devices. Like when I read about your profile, like I'm from IFCC Scientific Division, and so you have done like, you know, enormous work on POCT. So when we plan for internal audits for POC devices, we find the challenges during the audit. So what quality tools, quality indicators, or like, you know, audit plan and processes we can like for the POC devices in hospital settings?
What we do with the POC when we introduce it is we do first a method validation, so compare it obviously to our laboratory, and then once it's implemented, we can then follow up and see is it performing as it should, but also look at all the total testing phase of the POCT.
Thank you, Dr. Annalise.
Thank you.
And Dr. Annie, I really have to appreciate your audits. I'm still struggling with my audits. I haven't yet started them, and I really want to do them. I might take some more advice from you. Thank you very much, both of you.
Thank you.
Thank you, Dr. Annalise. Thank you very much for that wonderful talk. Audits are very much important indeed as a continual improvement for a laboratory. and your wordings, your lecture with regards to EBLM across the whole care pathway, the points that you brought to us is indeed really very touching, because these points would help improve quality of care, support innovation through more effective adoption of new technologies, and ensure more appropriate use of healthcare resources, which is very much required in today's scenario. I would like to thank Dr. Annalise for the wonderful presentations once again. Thanks to my co-chairperson, Dr. Krishnajyoti. Thank you, Dr. Seema, and the KHO team for giving me this opportunity to be a part of this panel. Thank you.